All right, class, let's just review this PowerPoint on all the information that I just got done talking about in the video. Again, reminding you about the Nurse Practice Act, what it does and what it defines, the scope of practice of our nursing profession. It sets the standards for education programs. It is also involved in licensure requirements, and it also has the authority to provide disciplinary action for nurses who might violate their scope of practice, and your Nurse Practice Acts are enforced by your state's Board of Nursing. So again, when we talk about licensure, it allows nurses the legal privilege to practice nursing as defined by each state's Nurse Practice Act, and each Board of Nursing oversees administration of a licensure examination. So this is very important for you as nursing students to ensure client safety. This is what you're responsible and accountable for in the clinical setting. You should also know facilities' policies, procedures before undertaking any clinical assignment. Ensure knowledge about client's condition, interventions, medication, and treatments, and never perform care if unprepared, and seek help before beginning procedure if unsure. And this is pretty easy to adhere by, especially when you have an excellent and a responsible clinical instructor, which I would have to say all our clinical instructors are evaluated on a yearly basis to make sure that they are upholding these principles when they are mentoring and guiding students in the clinical setting. So looking at the two terms, accountability and responsibility. Accountability is answerable for the outcomes of a task or assignment, and nurses are accountable for their own actions, may also be accountable for the actions of their subordinates or trainees. And responsibility is specific accountability or liability, and it's also associated with performance of duties of a particular role. And within our standards of practice, it provides a description of responsibilities, a minimum level to ensure safe and effective care, and that's how we evaluate people who graduate from a nursing program. We give them the authority to take the NCLEX, and remember, the NCLEX is great that you passed it, but it just shows that you're minimally competent to provide safe care to your patients. It acknowledges accountability for both successes and errors and helps a professional culture remain positive. And these are some of the consumer demands. Consumers are better educated, and a lot of that has to do with the internet, the accessibility of that. They have more knowledge about health and illness, aware of others' needs for care, and public's concept of health and nursing. Health is a right. Individual must assume responsibility for their health, and we need to continue to promote patient-centered care as well. And our consumers are active participants. And again, this accountability is not only influenced by consumer demands, but also by science and technology. Advances affect nursing practice, competency, accountability, and innovations have changed nursing education. Clinical training, simulation, things that we can do over the internet and by virtual clinical settings. We can provide students some type of clinical experiences. And our nursing practice of accountability is definitely influenced by our individual values and beliefs, our values, ethics inherent to profession as a whole, our social factors, and supported or undermined by individual RNs, and development of the nursing profession itself. And again, after all that is going on with this pandemic, it even puts the nursing profession in even more of a revered or a quite admirable profession, and it should, because the work and the dedication and the care that our nurses are providing out there is just unbelievable. and it's so proud to be part of that profession. Class, what we're going to do now is go over some of these activities, these case studies, so we can take that information that we've just discussed within our assigned chapters and even on the PowerPoint and apply them to real-life patient situations, okay? So let's start first with this case study or code status, which is our exemplar with Appendix 29. All right, let's get this a little more centered. So let's read about our patient, David Lewis. He's a 50-year-old African-American male who is recovering from a stroke at a rehabilitation facility. He is medically stable and able to participate fully in his therapies. However, he has requested DNR, which stands for Do Not Resuscitate status. He reasons that if he has another stroke or cardiac arrest, he would lose more cognitive and motor function, and then if he were resuscitated, it would place too heavy a burden of care on his family. Day after day, he and his family ask about the DNR order, which, remember, the patient cannot write it. The healthcare provider has to write that. He may request it, but he cannot legally write the order. The nurses working with Mr. Lewis repeatedly ask the attending physician for an order, and the physician continues to respond that Mr. Lewis does not need a DN order. He is stable. Finally, the primary nurse goes to the facility's ethics committee to discuss the problems. This results in another physician reviewing the chart, speaking with the patient and family, and entering the DNR order. So our first question is, what ethical dilemma did the primary nurse working with Mr. Lewis face? Think about it. The patient wanted a DNA order, but it was very frustrating for the nurse because the physician did not agree with that and would not write the order. So she was very, very much caught in the middle, in which she was unable to advocate for the patient. She faced a conflict between the patient's rights and values and the physician's beliefs that a DNR was not appropriate. So he made that call and not taking into consideration how the patient felt about it. Question 2. What principles did the primary nurse follow in going to the ethics committee? Well, she did determine that there was an ethical dilemma between the patient and the healthcare provider, and she communicated with colleagues to seek a solution that addressed the needs of all people involved. Maybe getting people involved that really were objective to the situation and looked at both sides of the spectrum. And she really was serving as quite a wonderful advocate for her patient, which is what we should do as nurses. She may have agreed with the doctor, but she was doing it on the better behalf of the patient's request. So this next question is, how do you feel about DNR orders and why? Well, I think we have to understand those are personal choices that people make, and DNR orders allow individuals to make those choices related to the quality of life that they want to live, and also a dignified death. A lot of people, just the thought of them having to be resuscitated really just upsets them so much, and they just do not want to go through that process. And a lot of people have an idea that anytime someone is resuscitated, that they're going to end up like a vegetable, or that resuscitation is always comes out with negative outcomes, and that's not always true. So they protect, but they do protect the right to self-determination in circumstances where patients may no longer be able to advocate for themselves, and that's a very good point that we make about DNRs. And one potential problem may be that the patient may incorrectly conclude that the quality of life would be impaired if they were resuscitated. And that's where that myth has to get out of that patient's mind, because many times we have had very successful resuscitation efforts which saved the patient's life, and they went on to live a very productive and good quality of life. So that's what we have to explain to the patient as well. And then this last question, number 4. In what ways did the nurses working with Mr. Lewis advocate on his behalf? How is the nurse's role as an advocate related to nursing ethics? Remember, we talked about different organizations and under the American Nurses Association Code of Ethics, nurses do have an obligation to promote, advocate for, and strive to protect the health, the safety, and the rights of the patient. And although the patient wanted a DNR order, the request was definitely ignored by the physician. The nurse advocated for the client by initiating the process of an ethics review. And sometimes when these things happen, because there's only so much the nurse manager can do and the supervisor can do, and that's why almost all these facilities do have an ethics committee where they could really make that determination and look at both sides of the coin to determine what are we going to do in the best interest for the patient. And that's the bottom line. It's not about how the doctor feels. It's about what is best for our patients and to keep the patient safe. And it was also probably determined that Mr. Lewis was in a coherent and sound mind to make that decision, because that's what else we have to determine. Even though he had a stroke, he was still very coherent and could make those determinations of what he wanted done in case something else would happen to him. All right, let's look at Appendix 30 again. Looking at the concept of legal, and our exemplar again is code status. Gary Casper has been in the hospital several times in the last year with a deteriorating diagnosis. After Chandra Lewis, the patient's RN, completes her assessment of Mr. Casper's current condition and his concerns, she contacts the case management department for assistance with his concerns regarding end-of-life care choices. Ms. Lewis tells the case manager that the patient's wife will not allow him to prepare an advance directive, which Mr. Casper wants to do, since he has decided to be DNR on this current admission. The next day, the social worker meets with Mr. Casper separately from his wife to discuss the right for self-determination and how to prepare an advance directive form. Mr. Casper is relieved that he can complete the form in the hospital, but he is concerned that his wife will still be able to prevent this, as he does not want her to have power of attorney for him. Plans are put into process for Mr. Casper to complete the advance directives with appropriate staff and another family member, while the medical provider speak with Mrs. Casper in a conference room. So we have another situation here that involves a conflict between husband and wife. So let's see legally where we as the nurse stand with this situation. So question 1, how does the staff support the patient's right to self-determination? And the answer to that is the staff supported Mr. Casper's right to self-determination by meeting with him individually and initiating the process of having Mr. Casper prepare an advance directive that is consistent with his own end-of-life concerns. And he is coherent, he's of sound mind, and he is an individual and does not need the permission of his wife to do so. And I want you to be clear on what the term self-determination means. It basically means the process by which a person does control their own life and makes the decisions about their life. So that's what that term means. All right, question 2. Did the medical provider violate the wife's rights to be with her spouse in this case? So explain your answer. And the answer is no. Mr. Casper is a competent adult who has the right to make his own decisions regarding end-of-life care. He does not need his wife's permission, even though they are legally bound as man and wife. Question 3. How can nursing staff further assist Mr. Casper in facing end-of-life care choices? Nurses, we have a lot of key responsibilities related to assisting patients to make their end-of-life decisions, and that is to first of all include and provide emotional support, providing teaching about life-sustaining measures, including correcting misconceptions and reassuring them that they have always the right to change their decision when they are competent. And that's a very important thing to make sure they know, that it's not written in stone. They can change whatever decision they make. So question 4, and I think this is a good one too, because Mrs. Casper is still very concerned about her husband, and we have to think about her mental health and what she's feeling at this time. So how can the staff support Mrs. Casper as she faces the end of her husband's life? And I think, she's scared. She's trying to hang on to the time that they have together. The staff can provide a lot of non-judgmental support to Mrs. Casper by letting her verbalize and talk about her concerns, acknowledging her feelings, and providing information that will alleviate her fears. So be attentive to her as well. This may be a couple who's been together for, who knows, 30, 40, 50 years, and they love each other dearly, and it's just very scary and frightening to think that she may lose her husband and have to live her life by herself. So these are why she's probably fighting for him to make that decision about being a DNR. So just something to think about. But I know as nurses that our nurses out there do look at both the patient and their families. So that's a good thing. All right, what I want to do now is just look at this Appendix 31, where the exemplar is scope of practice. And I want you to read this because I think this is very interesting, and it really does kind of talk about our scope of practice. You know, and why is this important to kind of address is, you know, we may be nurses who, after we graduate, you pass NCLEX and you get hired for a particular unit. There may be times when, you know, that your unit that you've been assigned to, the census may be down, and it may be your turn to float to another area of the hospital because maybe they're short-staffed and they need some additional help. Now, you are a registered nurse, but maybe you've always worked in, you know, labor and delivery, and now all of a sudden you got floated to intensive care or cardiac care, and you don't know the first thing about what to do or what to do as far as how to interpret an EKG or what to do when a patient comes in with chest pain. What's the protocol? So this kind of talks about that kind of a situation, because we as nurses all have like standard knowledge that we learned in nursing school. So let's go over this and let's see, you know, what this particular article means to you. This particular nurse, Jennifer Owen, has her BSN, and this week she's been talking about nurse practitioners broadening the scope of their practices in different states, how that would be beneficial and the organizations working for and against, and what states allow and others don't. But it dawns on me the term scope of practice needs some definition. She's been a nurse for a number of years, and she thinks I know my own scope of practice. So as a nursing student, I heard the phrase a lot, read definitions, but they didn't mean much since I really didn't have any practices to fit into that scope yet. Of course she didn't. She was still a work in progress. She was a student nurse, still learning. So let's take a look at what that nursing scope of practice is and how it is determined. To understand your nursing scope of practice, you must first know what defines nursing. The American Nurses Association provides a contemporary definition. Nursing is the protection, promotion, and optimization of health and abilities, prevention of illness and disease, and alleviation of suffering through the diagnosis and treatment of human response and advocacy in the care of individuals, families, communities, and populations. Okay, that sounds like a fancy variation on I want to help people. So as nurses, we commit to protecting the health of others and ourselves and others through education, hands-on care, and collaboration with other healthcare professionals. Those others we talk about can be found in hospitals, schools, neighborhoods, free clinics, doctors' offices, and next door. So again, what determines if we are we within our scope of practice to work with these other people? So let's go back to the ANA and nursing, scope and standards of practice. The scope of practice statement describes the who, what, where, when, and why, and how nursing practice. Each of these questions must be answered to provide a complete picture of the dynamic and complex practice of nursing and its evolving boundaries and membership. The profession of nursing has one scope of practice that encompasses the full range of nursing practice pertinent to general and specialty practice. The depth and breadth in which individual registered nurse engage in the total scope of nursing practice are dependent on their education, experience, role, and the population served. So now we have this textbook definition. It tells us we must answer certain questions to know if something falls in our scope, and it tells us there are lots of variables. So let's break it down, because even though we all went or are going to nursing school, because we all have or will pass our licensing exams, doesn't mean we belong everywhere. So for example, I'm an OR nurse. I know a lot about anatomy, technology, machinery and instruments, positioning, pressure points, and personality quirks of my surgeons. I am not an ICU nurse. I know how to take a blood pressure, use my stethoscope, and I actually still remember the differences between wheezing and rails. I no longer know how to set up a pump, am unfamiliar with the many kinds of cardiac drugs used today, and haven't managed a ventilator since nursing school clinicals. These skills are not in my scope of practice. So here are some guidelines determining your own scope of practice. Did I learn this skill or task in my basic nursing program? Every nurse, everywhere, should know how to take a manual blood pressure. It is a basic skill taught in nursing school. So if you determine that the activity was not part of your basic nursing program, try these questions. Did I learn this skill, task as part of a comprehensive training program, which included clinical experience? In my OR residency program, I learned about electricity and its uses in surgery, how and where to properly place grounding pad to prevent burns and other electrical accidents. I learned how to pass instruments, including knives, safely to the waiting hands of the surgeon, and how to assist the anesthesia provider with intubating the sleeping patient. All skills particular to the operating room environment. Has this task become so commonplace in nursing literature and in nursing practice, wound debridement and dressing, for example, that it can reasonably and prudently be assumed within scope? At one time, only doctors attended to patients' wounds, but wounds of all kinds, burns, diabetic, surgical, are also commonplace today that pretty much all nurses know or have been shown how to do it. Is the skill task in your hospitals, clinics, agency policies, and procedure manuals? If it is in your book, your employer believes it is a task or a skill that is part of the job you were hired to do, your scope of practice. Does the skill or the task pass the reasonable and prudent standard of nursing? A large part of nursing is using common sense, but reasonably and prudent is simple, showing care and thought of the future, pretty much the basic tenets of nursing. If what you are about to do fits those definitions, it is in your scope of practice. So if you can answer yes to all these questions, the skill or task is within your scope of practice. Scopes of practice are the same for every nurse at a basic level and very different by specialty. Whether or not you're in the OR, ICU, the ER, telemetry, pediatrics, etc. Education, an LPN, an ADN, a BSN, a family nurse practitioner, a nurse anesthetist, a DNP, and all those other initials, where you practice and who you serve. If you have a question about something you are asked to do, if you are uncomfortable with something you see, maybe it's not in your scope of practice, it's always better to hesitate. Ask yourself these questions and check with someone else before you commit your patient and yourself to a course of action you shouldn't be on. Stepping out of your scope of practice can be a legal issue and endanger that license that you work so hard for. So I think that's a really good article, and it kind of defines what is my scope of practice and when am I out of my scope of practice. And I think that's really a great advice. Are you uncomfortable? And if you are, it's better to ask and get help or have somebody else do it than to put yourself or the patient in harm's way. So I just wanted to go over that with you. I love that. I think it's a great way to assess it. And many times, if you get caught in that situation where you are floating to another floor that isn't really your area of expertise, you definitely want to say that to the charge nurse. And most of them are very understanding, and they're just happy to have your presence. But you are a nurse that can take blood pressures and help provide patient care. So that's why your presence and your nursing care and your ability to do that is very well appreciated, even though that might not be your area of expertise. All right, let's move on to the next questionnaire having to do with scope of practice. It's another case study. Appendix 32. All right. So we have at first glance, Nurse Rhea can tell Mr. Paul's condition has changed. As she asks him how he feels, Nurse Rhea knows he has short of breath. She can hear the anxiety in his voice as Mr. Paul replies that it is hard to catch my breath and his chest feels tight. So Rhea knows Mr. Paul was admitted overnight with general weakness and anemia after a fall at home. There was no record of any shortness of breath or pulmonary disease in his admission statement. So elevating the head of the bed so Mr. Paul can sit upright, Rhea begins her assessment. His respiratory rate has increased to 32, and he is using his accessory muscles to breathe. She notes his skin is a little clammy and cool, and his lips and fingernails are slightly cyanosed. She hears crackles throughout his chest and a decreased air entry into his left lower lobe. His pulse is 110 per minute and regular. Blood pressure is 108/60, and O2 sats are 86% on room air. So based on her assessment, Rhea draws a conclusion about Mr. Paul's status. She diagnoses him as having hypoxia related to decreased air entry to his left lower lobe as the likely cause of his symptoms. Rhea knows she can improve his condition temporarily by applying oxygen, stabilizing him until a physician or nurse practitioner can diagnose the underlying medical problem. So in deciding to treat, Rhea considers the risk, benefits, and possible outcomes, and in her judgment, the outcome is reasonably predictable and the benefits outweigh risk. She has the knowledge, the skill, and the judgment to follow her agency protocol for treating hypoxia, including managing any inattended and unattended outcomes. Examining her next steps to Mr. Paul, she applies oxygen by mask at 6 liters per minute, and reassuring him she watches for Mr. Paul's condition to change. Within a few minutes, Mr. Paul has visibly improved. His respiratory rate slows and his O2 sats increase to 90%. So her next steps include wanting to contact Mr. Paul's physician. Rhea uses the call bell to alert a colleague to come, and while her colleague stays to monitor him, Rhea consults with his treating physician and receives orders. She updates the care team and documents her ongoing assessment, diagnosis, treatment, and communication with the physician. So a great example of how a patient changes and what will she do within her scope of practice to hopefully alleviate the acute symptoms, but yet continues to monitor the patient and to see if the patient is getting better or worse, but then again communicating to the physician that this situation has occurred. So what conditions might you diagnose and treat in your practice? Sometimes, obviously shortness of breath, that we can change the position of the patient. Maybe it would be time for the patient to have their ordered nebulizer treatment given maybe a little bit earlier. Maybe it would be time for a medication to be given that might improve the situation that is occurring. So it could be a cardiac event. It could be maybe the patient's urinary output has decreased. Who knows? There could be a lot of situations that we could implement some kind of intervention. Now, the mask with 6 liters might be a little bit going above and beyond. I mean, I've really never put on a mask without a doctor's order. I've just, put on nasal cannula, usually at 2 or 3 liters. But I like the fact that she had another nurse come and sit with a patient to monitor him, and then she went immediately to the phone and let the physician know what changes had occurred with this patient. Do you see your process reflected in the steps Rhea takes in diagnosing and treating Mr. Paul's condition? Absolutely. I think she did the right thing. The great thing is, not only did she assess those signs of hypoxia, but she interpreted what they meant. I mean, right away she saw that his pulse ox was 86%. Well, she knew right away this is a very serious situation, and she had other symptoms and manifestations verify that, especially the way his lips and fingernails. But the thing is, it wasn't that the oxygen corrected the problem. It corrected that symptom, but we still have to get down to the bottom and determine why the patient had this respiratory problem. Maybe he's developed a pulmonary emboli. Maybe he's, maybe he has a pneumothorax. I mean, who knows what the cause of why this patient developed this shortness of breath, because this is definitely an acute situation, which was not in existence when the patient was admitted. He came in with anemia, so maybe he's having neurological problems that's affecting his respiratory status. Who knows? There could be all kinds of reasons. So is there anything else that could have been done for this patient that was within the nursing scope of practice? Like I said, if she had meds that were ordered that could have helped him, we don't know much about his history. We don't even know how old he is. But she did know that at the time of admission, there was no evidence of any shortness of breath or any history of like having COPD or anything like that. So this was an acute problem, okay? And I like the way she proceeded to assess him in so many different ways, respiratory-wise. She listened to his lungs. She noted that he was using his accessory muscles, which told her that he was definitely having some fairly serious shortness of breath. So that's kind of what we do, and she definitely stayed with the patient and definitely treated him with her in her scope of practice. All right, good job everyone with that. And it's a little difficult, I'm kind of giving you my take on this, but some of you may also have your own answers, which it's too bad we can't share those, but please, if you want to bring up any of these activities during our WebExes, please do, because I think these are very good to get that thinking going and get started on kind of critically thinking about the situation and what am I going to do for this patient? What can I think to do on my own without referring to any book? This is an individual patient with individual problems, and what am I going to do best for this patient right now? All right, so the next thing we want to do is go to our next exemplar called of accountability, which again involves our legal concept, okay? Okay, and that would be Appendix 33. All right, let's get this situated. All right. Linking the concept of accountability with the concept of legal issues. Question 1. What is the nurse's legal obligation to the client related to accountability, and how is it regulated? So I want you to think about that. I want you to kind of say in your mind, what is that difference between accountability versus responsibility? Remember, you as the nurse in charge of a team are accountable for providing quality care to all those patients, even if you're not the one delivering that care. Care is to be given according to and recognized and approved standards of care, which are used to legally define the care that we provide our patients, okay? So question 2, a nurse makes a medication error that results in harm to the client. The nurse demonstrates accountability by immediately informing the physician and nursing supervisor when the error is recognized. How does the nurse proper demonstration of accountability affect the nurse's legal responsibility? She does demonstrate accountability, but does not affect long-term legal responsibility for the error. The nurse is to provide care according to standards of practice. If these standards are violated and result in an error, the nurse is legally responsible for the outcome. So if something happens to this patient where he has to extend his stay, or there's another problem that arises because the nurse performed this error, she's responsible for whatever outcomes occur. So question 3, what is the nurse's role in assessment and appropriate interventions to ensure comfort in the client? The nurse is definitely responsible for making sure the patients are achieving a high level of comfort and providing effective interventions. The frequency of assessing the patient for comfort depends on the patient's health condition, and the findings of this assessment are to be documented. Is it a person that can get up and wash himself up at the sink by himself, or is it one that needs partial or total assistance? And that's where that assessment needs to be made so that each patient is reaching their maximum amount of comfort. Sorry about that. All right. Question 4. How does lack of client comfort impede the client's taking part in care plans and activities? Well, comfort is needed before any teaching or involvement in care activities can be performed. Think about it. If your patient is uncomfortable, learning will be impeded. Okay? Even if that's mental or physical discomfort. If the client is uncomfortable, the client will not want to participate in care, and this can definitely hinder the healing process. In question 5, how does the nurse's code of ethics reflect the expectation that the nurse is accountable when providing client care? A code of ethics is just one criterion of a profession. In nursing, the code of ethics guides behavior when providing client care, and by following the code of ethics, the nurse demonstrates accountability with client care. All right? So let's look at this one, because I personally have been involved in a situation like this. A nurse believes that the physician has written orders that may endanger the client. The nurse consults the physician, who refuses to alter the orders. What is the nurse's ethical obligation to the client in order to demonstrate accountability? The nurse is responsible to the client and therefore must take actions to protect the client from harm. This action might be in the form of contacting the nursing supervisor, medical director, or other organizational administrator who can intervene to support the nurse's actions to protect the patient. The nurse is responsible for providing quality care, which includes questioning orders that might be harmful. And if we do, as nurses, continue to follow that order when we know very well that it could cause patient harm, whatever occurs, we are responsible, because we are a profession of knowledge, and we are accountable for all the actions we take when we knowingly have that knowledge that that particular order that's carried out would do harm for the patient. So it's okay to tell a physician no, especially when it means that you're protecting your patient against harm. All right. And lastly, we're going to do this one case study involving Jen Sturgis that deals with the exemplar of accountability. This would be Appendix 34. Okay? All right, we have Jen Sturgis. She's a fairly new RN on the medical unit in a 245-bed hospital. On the evening shift, Jen started her rounds with her 5 clients. One of her clients was a 45-year-old female named Catherine Miller, who had been admitted with a GI diagnosis and also had a history of back pain. And during Jen's assessment of her pain level, Miss Miller said she was doing just fine, although she seemed very anxious. As Jen reviewed Miss Miller's vital signs, which the CNA had recently taken, she noted a blood pressure much higher than the usual. Jen commented that one of the symptoms of pain is a higher blood pressure, and Miss Miller described trying to overrule her body by ignoring its signals and having a dialogue between the body me and the real me. So Miss Miller said, if I refuse to pay attention to my body, my pain will go away. So Jen realized that Miss Miller, although actually in pain, might not be allowing herself to pay attention. Jen asked Miss Miller if she had discussed her pain management with her primary health care provider. Miss Miller laughed. My doctor tries to have me take narcotics, but I worry about those types of meds. As she spoke, Miss Miller's hands were gripping the bed sheets and she was shaking. She said, the pain is my enemy, and I don't talk to my enemies. Jen knew that ignoring the body signals of pain can cause serious consequences. The pain could intensify and the client's blood pressure could rise significantly. Jen realized that Miss Miller needed to get appropriate treatment for her pain. After her assessment, Jen discussed with the unit charge nurse her concerns about Miss Miller and her need for pain management and comfort. So let's start looking at these questions. Now what you can do with a lot of these activities is look at the answer, or look at the question, and then stop the video and then say to yourself what the answer you would probably provide if we were in the classroom, and then you can again play the video and see if we are in agreement. These are great ways to kind of discuss and collaborate our ideas. A lot of times there's no real wrong or right answer, but what's the best answer that provides the best care for our patients? So question 1, why was it important for Jen to complete her client's assessment before leaving the room? And as all nurses, we need to complete our assessments before leaving the room to make sure that the assessment is thoroughly done and that we have all the data needed to review prior speaking with the charge nurse or possibly the doctor's order. Finding out everything about the situation, not just seeing it, oh my God, she's refusing pain medication, but let's find out more of maybe what is the reason behind this. So she really did have all the data to help substantiate the situation with this patient. So question 2, what further symptoms did Jen observe while she spoke with her patient? Well, obviously the patient had a very high anxiety level. The patient actually reported a pain level, and she noticed that the patient was had blood pressure issues. The blood pressure was definitely elevated, and she also noticed that the patient was gripping the bed sheets. So there was a lot of nonverbal there that she was able to pick up about. So question 3, what information should Jen share with the charge nurse to assist in meeting her client's needs? She should share with her charge nurse all the critical assessment data, including the elevated blood pressure, her pain level, and also all the things that she shared regarding her beliefs of pain management and also that high level of anxiety that she observed. Question 4, with what staff should Jen and the charge nurse plan to collaborate to find a better method for managing Miss Miller's pain? We could talk to the pharmacist, the pain pharmacist. We could talk again to the physician, and again talk to the social worker as well. Those are all great other healthcare team members that would be very helpful to try to manage this patient's pain. Okay, so let's look at number 5. When a client refuses pain management, why should the nurse pursue other solutions rather than simply kind of giving in to the fact the patient doesn't want anything? Well, pursuing other solutions provides more thorough assessment data to create an individualized plan of care based on the patient's needs and priorities. Because obviously, as nurses, it's very important that we provide comfort to our patients, and we know what is physiologically occurring with this patient, as seen by that elevated blood pressure. When a patient has pain and is not able to have that pain resolved, and obviously it can interfere with her other problems and the healing process. So let's look at part B of this case study. So Jen Sturgis briefly but clearly discussed with the charge nurse, Melina Menendez, her concerns about Miss Miller's pain management and the objective symptoms she noted during her shift. Miss Menendez asked Jen what she thought was going on with Miss Miller. Jen told her that this was her first experience with a client who had a history of pain but did not want to use any pain medications and ignored her apparent pain while only resting in bed. Ms. Menendez was concerned that the client would be unable to participate in her care and activity if she had uncontrolled pain during her hospitalization. She asked Jen to join her while she spoke with Ms. Miller. After a few minutes of discussion, it became clear that the client was afraid of pain and narcotic abuse. It also appeared that uncertainty about the meaning of her body's pain signals worried Ms. Miller about the safety of her physical activities at home and in the hospital. Ms. Menendez gently held Ms. Miller's hand and told her how important it was for her to take part in care activities and to allow staff to manage pain and keep her as comfortable as possible. To help you with this care, Ms. Menendez said, I would like our social worker and clinical pharmacist to see you about your pain and needs while you are here. Ms. Miller agreed with this plan. So we obtained a lot of good out of this. And so we found out a little bit more information about our patient. And I was kind of suspecting maybe she was worried about becoming addicted to narcotics. And, with all the overdoses that we see out there in the community. So question 1. As the charge nurse, Ms. Menendez took an active role in further assessment of the client's needs and communicated with Ms. Miller in a truthful and calm manner. What aspect of ethical principles listed in the Code for Nursing students is this an example of? I think that's such a great question. So let's think about that. This is an example of communicate client care in a truthful, timely, and accurate manner. It's also an example of advocate for the rights of all clients. And question 2, if Jen had waited to collaborate with the charge nurse, would this have prevented further care and appropriate client outcomes? Explain your answer. Yes, the patient needed clarification of her concerns and support of her care plans and needs. And we also wanted to get approval from the patient. Remember, our philosophy is patient-centered care. And even though Ms. Menendez suggested, having the pain pharmacist and the social worker see her, we wanted to be sure that was okay with the patient. We wanted her to agree to those terms as well, and thank goodness that she did. So, we advocate, but we want it also to be in agreement with our patients as well. Be sure you view the video on responsibility versus accountability as well, just so I know that you're understanding the difference between the two. They're both very important terms in regards to care for our patients, but they really are not the same term and they don't mean the same thing. So please review these activities again because it presents to you a lot of great information and application of the information that was in your reading and in your assigned book. I really thank you for your attention. You guys did a great job following along with me, and of course I would have loved to have heard some of your answers in regards to these patient situations. Take care, and I hope to hear from you soon.